Okay, perfect. So again, welcome to today's webinar on the Well Women Project. To start today's webinar, I'd like to introduce our speaker, Dr. Arden Handler. Arden Handler's career reflects her long-standing commitment to improving the health of women, children, and families. She received her BS from Cornell University's College of Human Ecology in 1976, her MPH and MCH from the University of North Carolina in 1980, with a DRPH from the UIC School of Public Health in 1987. She has been on the faculty at the UIC School of Public Health since June 1987. She is currently PI and Director of the UIC Center for Excellence in MCH, and PI and Co-Director of the UIC MCH Epidemiology Program. Her research focuses on the exploration of factors that increase the risk for adverse pregnancy outcomes and examination of the ways in which the healthcare delivery system, particularly prenatal care, perinatal care, postpartum care, pre- and interconception well woman health care can amend these risks. She is currently the evaluator for the Illinois Breast and Cervical Cancer Screening Program, PI of the Kellogg Well Woman Project, and is working on a number of research projects related to postpartum care and contraception. She serves on a number of local, state, and national committees focused on MCH and is a former member of the SACM. And with that, I will go ahead and turn over the presentation to Dr. Arden Handler.
Hi, Reagan. Thank you very much for that lovely introduction, and good afternoon, everyone. I just want to make sure, can you hear me?
Yes, we can hear you.
Okay, so we can go to the next slide. And I just wanted to acknowledge all of my and our collaborators. This was an incredible collaboration between the University of Illinois School of Public Health and CityMatCH. And at UIC, Nadine Peacock, Vita Henderson, Chrissy Torino, Megan Gordon, and now also Megan Frank are involved in this project. And of course at CityMatCH, Chad Abresh, Denise Pecha, and Reagan Johnson were involved with the project. Next slide, please. So the goal of the Well Woman Project was to elevate women's voices about what makes them healthy and able to access well woman care within the context of their lives, within the context of their neighborhoods and cities. Next slide. We were very concerned about well woman care because of the disparities in women's preventive health care utilization. You can see from this slide that women who are uninsured, women who are low income, women who are fair or in poor health are much less likely to have a recent general checkup. And these are data that indicate that we really have a lot of work to do to improve women's health. Next slide. So our project basically, we were attempting to leverage the focus on the Well Woman Visit within the Affordable Care Act and in National Performance Measure Number 1 from MCHB to build support for the Well Woman Visit and Well Woman by listening to women's voices. Our goal was to gather women's stories with respect to the Well Woman Visit, and to really, in doing that, pay close attention to not just barriers to care, which I think we often, do surveys, what are the barriers to care, but to really understand the conditions of women's lives that really affect their ability to be healthy, to be well women, and also to access well women health care. We also wanted to develop a profile based on our findings of women's health in each of the 8 participating cities, and I'll tell you more about the 8 cities in just a moment. And then develop actionable recommendations to support well women and to really lay out what we think could be a woman-friendly health system in each of the cities and then obviously across the nation. Next slide, please. So these were the cities that were participating in the Well Woman Project, and they're from across the nation. We do have a swath of the middle part of the country that there's no representation, but we felt we were on each coast and in the middle as well: Boston, Chicago, Detroit, Jackson, Nashville, New Orleans, Oakland, and Omaha. Next slide, please. And we decided that we would capture women's voices in 2 ways. We decided to hold listening sessions in each of the 8 participating cities. The goal was to have 2 in each of the 8 cities. And then in addition, we wanted it to be a little bit of a less formal, more private and personal way for women to share their situations, their experiences, and their stories. So based on work that myself and Nadine Peacock had done several years ago on the west side of Chicago, we thought about having a story line or a story blog, and we decided to go for both, and we ended up developing a Well Woman Project website / blog and a 24/7 phone line where women could call in or write in their stories at any time of day or night. Next slide. And to reach women both in the 8 cities and then across the country, because we were both conducting listening sessions in the cities, collecting stories in the cities, and then collecting stories across the country, we used flyers, which we distributed electronically to our partners and to the cities. In this case, it was the City Health Department partners, but we distributed to all of our partners, like all of our collaborators and from our past lives, essentially. We also used memes, and this was my first time even hearing about a meme. I had no idea what that was before this project. We developed magnets. Some of you may have seen those. They were at several CityMatCH conferences. And we actually, in addition to the blog website, we had a Twitter account. And I still don't know how to tweet, but the younger folks in this project were very good at figuring out and tweeting for the project. Next slide, please. So this is just giving you an example of what our materials look like. This first one is a recruitment session, listening session recruitment flyer. So this is what we use to advertise listening sessions in each of the city. And actually we had 6 to 8 different images, and we rotated images. So you'll see from the next slide a different image, and this is the image that's on most of our materials, and this was on our magnets, and this was a meme for the stories, either for the blog or VoIP. And then the next slide, another image also, but in this case it was in Spanish. All of our materials were in English and in Spanish. Next slide, please. So we actually ended up conducting not 16 listening sessions, but we ended up conducting 17. One of the cities had 3 listening sessions, a large city where it made sense to have 3. They were conducted in either English or Spanish. 156 women participated. They ranged in age from 18 to 47. And for their participation, depending on the city and what was potentially reasonable in terms of the economics of the city, women received Target or Walmart cards ranging from $25 to $40. Once we completed the listening sessions, they were professionally transcribed, and if they were in Spanish, they were translated. And then we did analysis using Deduce, which is a software program that you use for qualitative data, to develop a whole listing of a priori and emerging codes, and eventually through the coding process to develop themes. And I'm going to be sharing those themes with you shortly. In addition, we had 99 women share their stories through the website, with 4 women sharing them over the message line. We really were focused on women of reproductive age, so we did, for our analysis purpose, exclude one story from one woman who was over 64. So we ended up using 102 stories that we annotated and memoed, and then also did coding in Deduce to get themes, and eventually we merged the themes from the stories and the themes from the listening sessions. I also wanted to say that in order to attract women to the stories, we did offer a raffle, and then that was on a monthly basis, and then as we came toward the end of this part of the project, we added additional incentives, which actually really boosted the number of stories that we received. Next slide, please. So now we're going to explore the themes. Okay, thank you, Reagan. So our themes really reflected what women were telling us and across the country. And so I'm going to just talk about the themes and then read a quote and then talk about recommendations. So our first theme is, no surprise, the healthcare delivery system is really not women friendly. And a woman in Omaha said, "Sometimes as we have low resources and we don't have enough money, we prefer to take something at home, and if you feel better, there's no need to come here. Besides, you come here and you spend the little you have, and honestly, you have to wait for a very long time to be able to see the doctor. You have to spend the whole morning here or the entire afternoon, and that is one of the reasons why sometimes I don't come. The second quote I won't read, but it's there for you. I'm pretty sure Reagan will send these slides at the end, or they're already posted on the Ready Talk. Next slide, please. So when we were creating recommendations, we thought about, we wanted to make sure that the recommendations that we came up with really responded to this theme, and so that meant developing strategies to really alleviate the complexity of the healthcare delivery system for women and make navigating the system easier. Things like decreasing time delays in scheduling healthcare appointments, wait times at the provider's office, and actually increasing the time spent with the providers during appointments. Just to also let you know, in terms of the recommendations, they were not developed, just out of our heads. Women were incredibly articulate about the things that they wanted to see happen in their cities, across the country, changes that need to be made in the healthcare system, in their communities, and so we built on the recommendations from the women. We also had a few instances where we took preliminary results with us on the road and got some feedback from stakeholders, and then we also borrowed from our back and forth discussions with each other on our own experiences, and then chats with other colleagues about potential ideas and resources that they've shared with us that made sense, that helped us develop recommendations that were responsive to our themes. So next slide, please. And here too, I won't read everything, but with respect to the healthcare delivery system is not women-friendly, we have many recommendations, but we put two on the slide. And what we were trying to do was give recommendations to the city health departments about what they could do in a system approach or a policy approach. We don't expect that you can change the FQHCs or the large health systems in your city, but the idea was you could be the leaders to engage your city health systems in a dialogue about all of these. So here we recommended engaging in a dialogue with large health systems and FQHCs to encourage increased availability of appointments outside of traditional hours, drop-in or walk-in appointments, more time per patient to facilitate patient-provider interaction, and an increase in online or phone consultation. I just wanted to make a comment about the last point, which is women really wanted to be able to talk to someone about their condition and figure out, well, do I actually need to go to a provider, or can I actually just get this answer to my question? And if I had that answer, then I can move forward from there. And that was something we heard a lot. Okay, next slide, please. So our next theme was that women's competing demands and priorities make accessing health care very difficult. A woman in Decatur, Georgia said, "Competing priorities get in the way of my ability to be healthy. Between work, child care, and home duties, there is little time left over for me to take care of myself. I worry about making sure that everyone else is well taken care of, that I often leave myself out." Next slide. So with respect to this theme, we really wanted to develop strategies that can assist women to prioritize health care. Next slide. Here we talked about a lot about the issue of whether cities had paid sick and personal leave policies. And so we basically said, if you're in a city without paid sick leave, could the health department possibly convene a citywide task force to discuss the whole idea of adopting paid sick leave for both public and private employees? And if your city actually has policies, do you have the educational materials that allow women to know that they actually are eligible for paid sick and personal leave? So that's what we recommended in response to this theme, and among many other recommendations. We're just highlighting a few in these slides. Next slide, please. Our third theme, related really to the first two, is that given the complexity of the health system and given women's competing demands that they face, women really weigh the cost versus benefits when deciding to access care. A woman in Detroit said, "I don't think a lot of people think that it's not important and brush it off. I think they think it's important, but it costs a lot, and some people just try to avoid it because of the bills. So it's not that they're just brushing it off. They just don't want to pay, or they can't afford it." Next slide, please. So our goal for this theme was to increase transparency and lower healthcare costs. And what we mean by increased transparency is that many women felt that they were going to care and not knowing when they would have a copay, or were told that they wouldn't be billed, that something was without a deductible or without a copay, but then in fact they found it to be with a copay, and they felt like they were coming and going and couldn't find out the correct information about what things were really cost so that they could actually weigh their decision to access care. Next slide. So in terms of our recommendations, we had many, but here are some examples that we came up with, one of which women talked about a lot, which was have one day or several days of Medicaid or free care several times a year for all women in the city. One was to develop a city fund to cover uninsured women and families struggling with high deductibles for their privately obtained insurance, and that was modeled on something that the National Breast and Cervical Cancer Program allows. And then other ideas relate to patient navigation and having a citywide navigation hotline so women really know which insurance coverage is available and what covers what. And that's a toughie, and it'll be even tougher in the next situation that we're in, but in some cities this actually does exist. Next slide. So in this theme, part of the weighing that women were doing has to do with their feelings about providers. And women really spoke eloquently about the relationships with providers and how key those were to their decisions about accessing care. And I think one of the issues that really resonated and came up in many places was that because of changing insurance and shifting insurance and networks and new alignments and new systems, women may be going to providers who they don't know or their family doesn't know, or they don't have the family history with that provider, and that's scary, and they don't feel like they want to divulge necessarily, and they want someone who listens to them and doesn't just decide, oh, you're such and such kind of person, I'm going to give you X, without really hearing them and seeing them for who they were. So a woman in Boston said, I found that the biggest barrier for accessing health care for me has been coming up against bias from providers. It's rare, but sometimes I'll walk away from an interaction with a doctor or a mental health provider feeling that they weren't really listening to me and had decided when I walked in the door what my problems were rather than working with me to figure things out. I don't feel listened to, and thus don't necessarily trust that the doctor is doing what's best for me. It's then really hard to challenge them, so I usually just end up switching providers. Next slide, please. So in terms of this theme, the kinds of recommendations we came up with were related to trying to increase trust, comfort, and the rapport between women and providers, including frontline staff. And a lot of women talked about it wasn't just even issues with the providers, but really not feeling necessarily respected by women, by the staff in the front office. Next slide, please. So here we came up with a number of things, one of which was the idea, and there are similar systems in cities, but we wanted to have health departments explore whether their city had this kind of access, and if not, some kind of women-centered, consumer-driven mechanism where women could evaluate providers and say, yes, give a check mark, this provider is woman-friendly, something similar to Yelp. And I know in some cities Yelp does work to do this, but we wanted cities to evaluate whether that was something that was possible or to build on something like that. Same thing, we expected this could very well be happening in cities, but to make sure that the workforce, many of the folks in the new health systems who had probably not always they're new places, not always familiar with different populations, that they were trained in cultural humility. And also the idea that women could possibly have apps on their phones where they had their history. So if they were walking into a new provider, they didn't have to start from scratch, and they could just share that possibly with the provider so that they could get comfortable more quickly and have a better rapport with the provider. Next slide, please. So we also found that many women talked about how they needed to empower themselves, that they needed to have health literacy, that they needed to know more about their bodies, and which reminded me of my old bodies ourselves days from the 70s. And they also needed to have insurance literacy so that they could have the right information, share it with others, empower themselves to make good decisions, and empower their friends and their sisters and their family members. So a woman in Boston said, I guess it's all about the information. And so asking and calling to make sure you get information and knowing about the different services and what you want, because it's all about questions. If you call and ask, you're going to get your services how you want them. Next slide, please. So our goal here in terms of creating recommendations was to figure out strategies that might enable women to have higher literacy and with respect to empowering them to advocate for themselves and for others. Next slide. So some of the ideas here would be to recommend that city health departments ensure that there's a citywide women's health hotline as a go-to resource for up-to-date information about changing health and healthcare guidelines. Women seemed to know that there were guidelines, but they found so much confusion in the guidelines, and they weren't sure, like if they looked on the web, were they getting the right information, and they weren't sure who was, where was the place that was, the final arbiter. We also talked about suggesting that women have an updated list of available providers, and on that list, what kinds of insurance they accept. I think a lot of the women on Medicaid in particular were challenged by providers not accepting Medicaid, and where providers or healthcare sites offer free or sliding scale services. And we also thought about, the cities can work with women and do trainings and provide resources to have women be able to advocate for themselves and their families with respect to talking to the providers, the insurance system, the whole delivery system. Next slide, please. Women also talked about mental health and that you cannot be a healthy woman unless your mental health is intact. And a woman in Olympia, Washington said, I would say the biggest factor that affects my overall health is my mental health. After having my first child over 6 years ago, I have really struggled with depression and anxiety. I had severe postpartum depression and have continued to have depression and anxiety since then. When I'm mentally well, it's easier to be physically well. I have the energy to cook, exercise, and care for myself. When I'm not mentally well, I have a really hard time being physically well. I gain weight. I stay indoors. I sleep. All of my energy is used simply trying to survive. Recently, it has taken me 4 months just to call my doctor for an appointment. It's one more thing, and one more thing that gives me anxiety. I don't know the solution, but I think a recognition that mental health is important to overall health is a starting point. So next slide, please. So with that in mind, we, probably a very simple solution here is that to make sure that there's accessible, affordable, and mental health care, and that it was also to work on breaking down barriers about the social acceptability of using mental health care, because in many communities, people don't want to acknowledge their pain and acknowledge that they should be seeking mental health services. And so we thought it would be important to also come up with recommendations that support that concept. Next slide. So we talked about two potential recommendations here on our list were the health departments to work with community partners to ensure the availability of community-based resources for self-care and respite. And even though this sounds like maybe touchy-feely, but things like yoga and mindfulness and stress reduction and exercise and drop-in centers, many communities don't have those, or if they do have those, they're unaffordable. And there might be ways to have community-based organizations more involved in this kind of thing to give women a place to go to get space and improve their mental health. And also initiatives similar to something that I've seen in some cities where women could have increased access to mental health care through their primary care providers, such that the primary care providers could call a psychiatric consultation line to use to get information about the patient, their diagnosis, potential treatment. Same thing, similar to like a telemedicine approach as well. Next slide, please. We also found that women talked about having healthy food, a safe environment, and an opportunity to be physically active in order to be healthy. So a woman in Hiawatha, Kansas said, the cost of health care and being healthy in general is a challenge, even as a middle-class citizen. Let's not forget the crazy costs of health foods. Our frugal family manages to get most of the health foods we want or need, but we do so by shopping sales mainly. That's a tough one when Walmart's the only option for 10 to 15 miles. Otherwise, we're talking extra money for gas to the grocery shop too. Next slide, please. So our goal here was to come up with recommendations related to increasing accessibility to quality food and safe, affordable environments for physical activity. Next slide. So we talked here about the idea of food prescription approaches, community-supported agricultural programs, partnerships with local farms and health departments to increase accessibility to fresh fruits and vegetables, work with FQHCs and health systems and other stakeholders to allow women to apply for SNAP through their health care provider, and work with community partners to support the provision of community-based programs focused on using and cooking healthy foods. I don't know how many of you have heard of Cooking Matters, which is a great program that does that kind of thing. Next slide, please. So we also found that women talked a lot about social support, and that if they had the appropriate social support, they were more willing and able to seek care. So a woman in Anchorage, Alaska said, "Unfortunately, we live in a time and place where many of us are separated by long distances from our family and do not have a good support network to help raise our families and get through life. The lack of this type of support system that people have had in most generations before ours is a huge barrier to maintaining a healthy lifestyle." Next slide, please. And so we wanted to create recommendations related to promoting women's social support networks, both their personal but also potentially system facilitated if women don't have personal, and if they feel networks, and if they feel isolated and alienated, maybe there are ways that we can bring other women to bear to help them to feel less isolated. So the next slide shows our recommendations. And we talked about maybe health departments working to develop a cadre of women's health peer advocates. They would be volunteer or paid depending on the situation, who could be potentially present at women's appointments, or maybe facilitating more increased group approaches to care. We know about centering pregnancy for prenatal care, but maybe there should be increased group approaches for other care, types of care for chronic disease, for family planning, so that women could get the support that they need while they're at the health appointment. Next slide, please. We're almost getting through the themes, folks. I know it's getting a little long. Lack of child care and transportation were major impediments to accessing health care. And a woman in Oakland said, "So I've skipped an appointment because I say, how are they going to be examining me with 2 children there? I don't have any place to leave them." And next slide. We really wanted to come up with recommendations related to improving transportation and accessibility of public transportation, and also women's ability to obtain child care while they're trying to go to a health care visit. And so our next slide recommendations are, next slide, Reagan. We had a lot here, actually, and I know sometimes the City Health Department might think this is out of their purview, but the idea is to partner with departments of transportation and other systems. So we talked about working with health systems and FQHCs to explore partnerships related to ride-sharing organizations, work with the Department of Transportation to explore plans for women and child-friendly public transportation, including special seating for where you put the child care safety seat and the stroller, potentially free parking vouchers or free or discounted bus and train cards, also some way to come up with supervised child care facilities if there's a large enough health provider site where this could happen, so that women are not told, well, you can come but you can't bring your children, and then where's she going to leave her children? We heard stories too of women getting the Medicaid provided van would come and say, okay, taking you to your appointment, but we can't take your 2-year-old and your 4-year-old, and so then she couldn't go because she had no place to leave her children. Okay, next slide. And our last theme is sort of a very interesting one, in that we found women that were very fearful. They were fearful about finding out they were sick. They were fearful if they didn't find out they were sick. They were just fearful of the system. They didn't feel like it was going to help them necessarily, or it was going to give them bad information or bad advice. And there was just a lot of anxiety about using the healthcare delivery system. And I think that shows us sort of like we're talking about replacing our health care program that we have, the Affordable Care Act, but there's so much more to it than just the insurance, right? There's how you interact with the system. So a woman in Jackson said, especially if you're not comfortable or your mother is in the room when you're a teenager and you're kind of afraid from that stage on in life, You kind of grow up like that, afraid to talk to your doctor, being afraid for confidentiality. Do I really tell her that I have a history of STIs, or do I not share that information? Or I've had an abortion, do I tell my doctor this? Even though that's an important part of education, knowing your body, reproductive health. Next slide, please. So we wanted to come up with some recommendations related to decreasing women's fear. Next slide, please. I don't think we did a great job here, but we did talk about providing trauma-informed care training for providers, and I think that would go a long way. We don't know how much of the fear was related to real deep trauma, but there just seemed to be so much anxiety that we thought this would be a good recommendation, and came to us when we presented in front of the Preconception Health and Healthcare Initiative, and Debbie Allen from Boston suggested it, and we said, yes, we love that. And so we included it in our list of recommendations. Next slide, please. So in addition to all of the themes that were across the cities and across the stories from across the nation, certain cities had specific themes, and there was a overall theme of discrimination, either based on race or ethnicity, or based on insurance, or based on citizenship, or based on ability to speak English, and that was prevalent in various cities, and you can see this on the slide. But the one other finding that I think was really telling was that for many women, they talked about not using preventive services because pregnancy was their introduction to the healthcare system. They weren't sure they were covered for preventive care, and they knew they were covered for pregnancy, and that's where they first accessed care, and that's sort of their idea of what care was. And so I think that's a really important point for us as we think about going forward in terms of recommendations and trying to meet women where they're at and every point in the healthcare delivery system. So if women are entering for the first time in the prenatal period, then we have to really emphasize in the prenatal period the importance of the postpartum and the extended period where they may or may not get pregnant after that delivery. Okay, next slide, please. So we are in the process of disseminating. We realize our results are coming at a very important time because there's a lot of emphasis on the Well Woman Visit right now because of National Performance Measure number 1. And so we have been just presenting like crazy, and we're having fun sharing our information and ideas and hearing from all of you about your ideas. So we've been doing that. We have developed city-specific well woman profiles based on this infographic look, and I'll show you what one of those looks like. We are developing a policy brief, and we'll be starting a manuscript. We've been presenting our findings and at national conferences and webinars, and there will be an e-learning module through CityMatCH where many of the things that we've talked about today, the recommendations, there'll be resources available to you, and I think Reagan's also trying to get from you through this the chat box, the resources that you have. We want to have as comprehensive a list of resources as possible. And we're hoping that we're not going to just stop here, that we can get some funding to continue to help the cities build on what we found and hopefully work on implementation of recommendations. Next slide, please. And this is sort of what one of our profiles looks like. They've already been changed. The paragraph on the top has already been improved based on comments we got from Chicago. And we've been finessing these, but this is a draft of what a profile looks like. This is the first page where we just, what is the Well Woman Visit, and then what women in Nashville said. And the next page where we both include city and county indicators of women's health, and they're not just about healthcare visits, but also about the social determinants of health, and then we provide some of the recommendations. We will be providing the cities with these profiles in a program called Canva, but also in Word versions, and giving them back all of the results and all the quotes so they can swap these out and use quotes that might be more meaningful for them, or more comprehensive list of recommendations in their, trying to use it for strategic planning, grant writing. If they're working on some kind of navigation project, they can say they have evidence from this project. So we're hoping this is a useful set of findings for the cities that were involved, but also for all of you. Next slide, please. And I think this just shows you our timeline, and we are at the end of this project. The project does end April 30th of 2017. And I think that's the final slide. Just here is how to contact myself and Reagan. And then I think Reagan takes it from here.
Yes, thank you very much, Arden. That was a wonderful presentation. We are going to open up now before we move to a different part of the webinar. And if anyone has any questions, comments, anything they would like to add for Dr. Arden Handler, you can go ahead and unmute your line. And again, to unmute your phone line is *7.
Thank you, Reagan.
Hello?
Yes, go ahead.
Hi, I'm calling from Los Angeles County, California, and I just noticed the choice of cities. There weren't any cities in Southwest United States.
Yeah, we were limited in the cities we could choose, and there was sort of a whole series of serendipitous reasons. So it was a small project, and we just ended up with a list of cities that Kellogg was interested in, plus cities that we had some familiarity with. We picked Chicago because I'm here, Omaha because it's a CityMatCH. So it was not. We wrote the grant in 3 days over Christmas, and we didn't have much time to get anything together. We just there was some extra funding, and we just had to go for it very quickly.
Congratulations, going for it.
Yeah, thank you. But I feel badly. Would love to have done it in more places.
And then it looks like we have a question in the chat box from Ashley, and she asks, is there demographic information available for those that participated in the listening sessions through the website?
It's not on the website. So is she asking if it's in both places or just the listening sessions? We do have demographic information for the listening sessions. And in terms of the website and blog, we were not able to collect very much. We just asked women to tell us their city and their age. We also didn't want it to be invasive because that was a more confidential site. It wasn't like we were involved, and so we didn't want women to feel like they had to leave a whole lot of information. So for the for the blog and voice over IP line, we could only get the age and city. For the listening sessions, yes, I don't have that right in front of me, but it was a mixture of Latina, African American, and European American women of the ages, of the reproductive ages.
Hi, this is Katie from New Mexico with a question.
Sure.
You mentioned, and I was distracted for part of it because someone came into my office, but you mentioned that one of the comments was about, I wish I had kind of a phone triage system that would tell me whether I need to really go in. It would save me time. And I thought of, in New Mexico, we had a nurse advice hotline for a very long time that was very successful. Was that one of the interventions that you were going to look into, or did you even question or find out whether in those cities such a thing existed and it was just a disconnect for the commenter or the woman who was giving her story not knowing about it?
So what we did is we went back to the cities with our findings, of course, and so they would say, oh, we actually had that. So in some of the profiles it doesn't say do this, it says continue doing this, or support or provide support for. But that's what we found, that as women would say things and then we would discuss it with the cities and they would say we have something like this, or we've been thinking about something like this, or not in that city, but we would mention it at another conference and someone would say, oh, we do that, or this is a website that people can go to. So I think these are not rocket science in many ways. They're good healthcare. I mean, what you're talking about is a wonderful model, and so I think the more, if you could put that in your chat and just talk about what that was, because the more we can draw on, and cities can use resources that existed before, or exist now, or other cities sharing and learning from other cities. That's we don't want to reinvent the wheel. So right. I think that you're making a very good point, and a lot of times these things got cut because we're cutting infrastructure, and we'll be cutting more infrastructure as the next 4 years
right.
unfold. But I think we have to try to be as efficient as possible and not reinvent the wheel. So that's
right.
a really, really good point.
Great. Thank you.
Thank you.
All right, we've had some really great questions so far. Does anyone else have any questions related to Dr. Handler's presentation?
Slides will be available.
Hi, I was wondering if you can go back to the slide with all of the contact information, please.
Sure. So I can give everyone a minute to jot this down, and then if there aren't any other questions, we'll go ahead and move to the next portion of the webinar. Oh, and to answer a question that is in the chat box, the slides will be available and the recording will be posted on our CityMatCH website. Okay, and I will have that contact information again available at the very end of this presentation, so if you weren't able to jot it down now, you will have one more chance during the webinar. And like I said, they will be posted as well. So I would now like to, again, my name is Reagan. I'm the project coordinator here at CityMatCH for this project. And I will be facilitating this discussion time along with Denise Pekka, who is the Director of Programs here at CityMatCH. And while we greatly enjoy being able to share the work we are doing around Well Woman Care and the Well Woman Visit, we would like to utilize a large portion of this webinar to hear from all of you on what you are doing to improve or advance well woman care in your communities. We hope that this time will serve as a great learning opportunity and an opportunity to share information between everyone. So attached to the Ready Talk email that you all should have received, the reminder email, was a PDF document, and this provided a list of themes and recommendations from the Well Woman Project. So it's everything that Dr. Handler presented on, but it's in one handout. And if you do have access to that, that would be something helpful to have available right now. So to start things off, we would really like to hear from all of you about which of the themes and or recommendations really resonated with you. Maybe it resonated because you're currently doing work to address it, or maybe it resonated because it is a problem you have identified in your community and you would like to address it. We want to hear about the work your community is currently doing or is hoping to do around the Well Woman Visit and Well Woman Care, as well as any successes or challenges you've encountered or experienced while doing your work. So with that, I will go ahead and open the floor for discussion. And as a reminder, to unmute your phone line, you will need to press *7.
As a reminder, *7 to unmute. We know that there's a lot of you that have interest and have things going on in this area, and some people have posted resources in the chat box. So feel free to take this opportunity to talk about what really resonated with you, what you thought maybe was missing, or what you're particularly interested in.
Hello, can you hear me?
Yes.
Okay, hi, I'm Annie Budiso. I'm from the Canton City Health Department located in Canton, Ohio. One of the things that we're currently working on is centering pregnancy, which is group care. But we're having a difficult time creating interest and keeping the women interested in the group care. So they regularly say that they lack social support, but when we are offering social support, they don't have an interest in it. And we've already addressed things like transportation and child care, so those are not the reasons that they're not coming. So when you say social support and offer group care, what else can we do besides those things if group care isn't something that our community wants?
So this is Arden again. I think centering is great, but I think it's very difficult to pull off. We've had experience here in Illinois also where, women often don't want or can't keep up with it, and I think it is difficult to do. So maybe would some kind of buddy system work better, or so that women don't have to come to a group and share in a group, but maybe that there's some kind of pairing, offering women that kind of thing, a peer. It's almost like a doula. It's almost like a doula support instead of the centering.
Wonderful. Thank you so much.
Okay, you're welcome.
Okay.
So if others out there have other suggestions on things they're doing around social support or other ones, and we've had some comments that people aren't sure about what page, what document that was sent. That's not necessary. If you've been listening or watching the webinar, just what struck you or what you're doing around Well Women Care. This is a great opportunity to get to network. This is a learning network call, so it's also about finding out what's happening with others across the country. Take this opportunity.
Hi, I don't know if y'all can hear me. Yes? Okay. So my name is Chloe. I'm in New Orleans. I'm with the Bureau of Family Health, and I know there's a few of us on this call today. And I kind of just wanted to chime in because this is very timely for us. We are about to embark on a research project with some key providers, and our interest in doing that was to determine if providers are providing culturally competent care, and if we were sort of inspired by the question of it's not a matter, or the statement of it's often not a matter of access, but a matter of treatment. So we're very interested in the kind of treatment and respect that patients are getting when they're going to some of our public clinics. And one of our key questions in this revolves around well woman visits, because we are interested in finding out if women are going to providers and feeling like they're, for lack of sort of a nicer phrase, not just being viewed as baby vessels, basically, but sort of trying to see if providers have that whole woman perspective, which I think really speaks to that theme 4. Relationships with providers are key to women's decisions. If they think that they're really being seen as people and whole people, as opposed to sort of a set of specifically women's health problems, we think that might affect their decisions about accessing care and getting the preventive services that they need. So I think like I said, this is very helpful because we haven't started the research yet. We're sort of in the final stages of formulating an interview guide and sort of getting set up to do that. But we'll definitely want to be following up with y'all to maybe get some of those, the profile for New Orleans. I thought New Orleans was on the list of places. But really, this is, like I said, for Louisiana, and specifically for this project of the Bureau of Family Health, we feel like we're kind of embarking on a new pathway for us, and ultimately we hope to use this research to develop some sort of social marketing campaign or activity, but we're not sure what that will be yet, of course. But just one more thing I wanted to mention, our big goal in doing this is not to target the women themselves or the people that, the patients really. We really want to change things on a higher systems level. So working with providers or working within clinic systems.
This is Arden again. I think that's great, and New Orleans was definitely one of our cities, and we worked with the health department there. I'm not sure if you were not aware of it, but there will be information coming back to New Orleans. But one thing that I think one of the recommendations we had for all the cities was the idea of sort of like a woman-friendly, what does a woman-friendly health system look like? Could the city health department develop a charter or a framework? But even for providers, this is what democracy looks like. This is what a woman-friendly health system looks like. This is what women need, and I was even going as far as saying, although this would be difficult with the provider community, but trying to figure out, can women rate their providers? I was involved in the 70s in something called HERS. It was a health evaluation referral service, and women called in. It's like a Yelp thing where women called in their evaluations, and if you needed to go get, prenatal care, or you needed to get a well-woman visit or any kind of care, you could look and see who evaluated which providers, and you would say, oh, these are women-friendly providers. So we would have to do it. I mean, I know it's delicate, and you'd have to do it in a way that, is not demonizing providers, but supports them to be more women-friendly, and maybe coming up with this is a women-friendly checklist or that kind of thing would be a potential way to go.
Thank you. Yeah, I think that it's a bit too early to say what our final direction will be, but we are thinking that it will likely involve a very close and intensive partnership with a few select clinics, and that's certainly something that we should add to the list of opening a conversation with them about.
Great, thanks.
Hi, my name is Anissa. Can I comment on that as well? I'm an OB provider, and when you're talking about reaching providers and offering culturally competent healthcare provision and training, sometimes when providers hear that, culturally competent, they think, well, I'm great to all my patients. I don't need that, and they want to move on to the next topic or opportunity. But maybe framing it in a way that, this is an opportunity to expand your patient base. We're going to provide you with information that can help you to reach and retain more patients. But I think there are certain words that you hear in the medical community and you think, okay, that's been overdone, that's been overplayed, I think I'm fine with that. And I don't think they have any bad intent. I think it just is you don't know what you don't know, and they think they're set.
I think that's
Hi, this is Callie.
I just want to say I think that's a really great way of framing it in terms of, I think people don't want to be preached at, so that's, we were giving like a first-line strategy, but it clearly it has to be done in a way that's going to appeal to providers, and that was a really great comment. Thank you.
I know there's somebody else with a comment, but along the same line, this is Denise from CityMatCH. I wanted to share that some folks in Seattle worked with women on doing digital stories where women just talked about their experiences receiving health care, and they actually then shared that with providers. And providers said that was actually very, very powerful because they thought that they had good processes in place and that they were checking the boxes and that they were doing what they were supposed to be doing. But hearing from several women in a row talking about their own experiences was pretty powerful, and letting them know that sometimes it doesn't always translate into reality, or it's not the experience that women are having. So that's just another suggestion and thing happening out there.
Hi, my name's Callie. I work at the Louisiana Health Department with Chloe in the Bureau of Family Health, and just wanted to kind of elaborate on a couple of the things that were already said, because I think today's presentation was great, and it provides a really good perspective on sort of the way that care is provided, or how we get women into those well-woman visits. And another element that we've been thinking about a lot, I work on our Title X program, and so I'm a little bit more closely connected with the clinical service side of things, is there's a well-woman visit, but what needs to happen in that visit, and how do we determine if that preventive visit is being used to its full potential to really have a good impact on a woman's health and her life, and being able to very clearly communicate what our the recommendations to providers about what needs to happen, what happens on that visit and how it happens. And so I'm not sure who it was that jumped in that said they're an OBGYN. I think that was a really great comment, and that's something that we also are trying to become better experts at. Is we do a lot of research around what do we need to tell providers or what do we need to train providers on. And I think an area of growth for us is how do we effectively engage with providers and bring them training that they feel is useful, that they feel is effective, and actually give them the skills they need, and that doesn't feel like it's the same old, but is something really that makes them want to partner with us and want to work on these trainings.
Great, thank you. There's a couple comments that have come into the chat box. Somebody had mentioned that what really resonated them was the talking about the need for mental health, and that's what they're experiencing as well. And I know that's fairly common. So this would be a time if anybody has any really kind of great solutions to maybe work that you're doing around trying to, because we know not only all the stigma, but just plain accessing mental health services is difficult in most places. So we'll pause for a minute to see if anybody has any creative solutions in the communities that you're in. Yep. Okay. Feel free to give a shout out or type if you do. Then Ashley from Minneapolis. She's not on audio, but she asked that we make a point of reminding everybody about the role of community health workers, and that they can be a great partner in doing this work moving forward, thinking about both providers and the women. So again, we'll throw that out there if anybody has any experiences they want to show about how they're using community health workers.
And again, to unmute your line is *7 if anyone's having any problems with that.
Okay, hello?
Yes.
Hi, hello everyone. My name is Felicia Haney. I'm the project manager for Indianapolis Healthy Start in Indiana. And the topic of the community health workers has come up. With our program, we work with, of course, pregnant and parenting moms up until that child is age 2. We have our community health workers that work with the interconceptional care side for our moms. So they are their advocates when they are going to their follow-up appointments, talking to them about breastfeeding. If the mom is trying to get back on her feet because of how the work environment is and she needs to go back to work immediately, our community health workers have been very vocal as far as helping them to not only do self-care but also sustainability, and encourage that mom to do the additional searching for resources and referrals. Our community health workers definitely provide the initial help with that mom, but they also encourage that mom to be self-sufficient as well, too. So our community health workers, we're currently going through the Healthy Start Epic Center. There is a community health worker module that is available to all the Healthy Start projects where regardless if you're a case manager, prenatal counselor, or what have you, everyone can take this module and receive badges, and it really breaks down what the purpose of a community health worker is. And then there's also, of course, national certification programs as well, too. So we definitely try to use our community health workers to the utmost capacity because they really are the link between on the groundwork. Some of our community health workers are part of the catchment area that we provide services to, so they're very knowledgeable about the area that they are assisting our pregnant and parenting moms in.
Great, thank you.
Okay. We have another question in the chat box, or kind of more of a comment from Pamela. sorry, Pamela. She says she's trying to talk, but we can't hear her. So she's in St. Louis and says that they're discovering that it's really about the environment. So I'm not, Pamela, if you can put more detail, because that could cover several areas. Then she says, and that women are living in trauma, and I know that Arden touched on that when talking about really kind of that overall, the fear, the anxiety that was coming across, and how that can act. Oh, wait. Okay, Pamela is typing. Sorry, I was trying to see what she was doing. She's talking about that they, around the environment, that they actually handed cameras to women and asked them to tell us why too many babies were dying. But in those pictures, they showed environments with horrible housing, no transportation, lack of jobs, and that's part of what they were telling in the pictures. Some of that was being shown. Thanks, Pamela. Okay, we can see who a lot of you are, and I know a lot of you have some really great stuff going on and have been thinking about this. So please, I know many of you and you're not shy. So *7 to unmute, please. This is a great opportunity to share with others.
Hi, this is Annie Budiso again at the Canton City Health Department in Canton, Ohio. Our community health workers, they do link our ladies up with mental health care services. They do screen for postpartum depression, and they also screen for depression prior to their pregnancy. We basically have our mental health recovery people on call. They can get them an appointment, if not the very same day, at least within the next one day. And they will go out to the house and they will see the women if the women choose to be seen. So if transportation is an issue, our mental health workers will go to their own home and talk with them. So that, that's just one more option.
Can I ask a follow-up question to that? Are those like community mental health center mental health
Yes.
folks? Okay, and so then who pays? I'm just curious.
That is a good question. I'm the epidemiologist for it's called Thrive. It's basically trying to address Thrive, correct?
Okay. Mm-hmm.
It's trying to address our disparity in Black and white infant mortality in our specific community. But we are thinking outside the box. We do know that transportation is always an issue, and just like someone said, so maybe we check the box that they are able to get transportation to and from the appointment, but maybe that time doesn't fit in with them, and what do they do about child care? So, all those things are issues. At least there's something that we could implement to bring someone to them. But yes, cost, that's a wonderful question I've never thought about.
Okay. But that sounds actually like a really great scenario, though, where a mental health worker can go to the home. That's incredible.
Mm-hmm. Thank you.
Okay. You can still, it's not too late to still unmute yourself and shout out if there's something that you want to share or a question you have. There have also been a couple questions about if we're thinking about replicating this or kind of what the next step. And of course we're thinking about that. We're in discussions about what that next phase looks like and that next step. So stay tuned. And there will be continued, I think we touched on a little bit, and is there a dissemination slide last? We talked about that. There's lots of ways and that we're going to be continuing to disseminate this information and involving the cities.
I had one question though for folks. We still have access to the story website, and it's not been active because we haven't been advertising. But if people think that would be valuable in some way to continue that aspect of the project, if anyone has an opinion about that, or if people think that's redundant with things that are already going on. I just was curious if people thought that was valuable for us to try to continue in some way.
Star 7 to unmute.
Okay, so everyone can feel free to, again, chime in if you have a comment about Arden's question, any additional things to add. I will go to the next slide. So at the beginning of the webinar, I asked that if anyone had any resources available that address the Well Woman Visit, Well Woman Care, or even just in general women's health, to leave comments in the chat box on what those resources were and links to the resources. But I did want to give people a chance, if your organization has a really great resource that you would like to share with the group, now would be a great time for you to unmute yourself doing star 7, and you can share any information about any of the resources you have available for people to use. So I did see earlier that someone from ACOG listed quite a few resources. I was wondering if there was anyone on the line from ACOG still, and if they would like to give us a little bit more information about the resources that they listed. Okay, so it looks like we have a few people leaving some additional resources in the chat box. So like I said before, I'll make sure to get those resources sent out. And then we can go ahead and wrap things up. So the webinar recording and the slides are going to be available, like I said earlier. Those will be available on our CityMatCH website. Please allow for a few days for us to get that recording up. And then following this webinar, you will also receive a post-webinar email from ReadyTalk. It will contain a link for a webinar survey. So if everyone could take just a minute to fill out that brief survey when you receive that email, it will be through a SurveyMonkey link, and it will take you no more than 5 minutes to complete that survey. It's very short. If you have anything more to add to today's discussion, please don't hesitate to reach out to myself. Again, my name is Reagan, and my email is listed there, along with Dr. Handler's email as well. So it's very valuable for us as we move forward with this project to learn about all the initiatives, programs, and resources that are out there. So we really like to hear from you all, especially if your community is addressing any of the recommendations we put forth. It'd be wonderful to have a model that we can provide the cities that participated to help them address those issues in their community. So again, if you have anything to add, feel free to just shoot us an email. And lastly, I would like to extend a sincere thank you to our speaker, Dr. Arden Handler, for her wonderful presentation, and to Denise for helping to lead our discussion time today during today's webinar. And thank you to all of you for taking time out of your day to attend and participate in the webinar today. And with that, we will go ahead and conclude the call. Thank you very much.
Thank you.